Hello, everyone, and thank you for joining today's program, Cervical Cancer Screening and HPV Myths and Facts. My name is Kristen Power, Director of Communications at the Nevada Cancer Coalition, and I will be serving as moderator for today's webinar. The Nevada Cancer Coalition presents this webinar with funding from the Nevada Division of Public and Behavioral Health's Women's Health Connection. Before we get started, I wanted to go over a few housekeeping items. First, please make sure that you are logged on to the webinar using the link that was provided in your confirmation email so you can follow along with the presentation slides. We have muted all participant phones to provide the clearest audio possible. You will notice a chat box in the bottom left corner of your screen. If you have any questions, please type them in the chat box and we will address those questions at the end of the presentation or as time allows during the presentation. A recording of this presentation along with a link to the post-test will be available on nevadacancercoalition.org within 1 day. Click to the Healthcare Providers tab and select the Cancer Screening Training Modules option. If you're pursuing the Nevada Cancer Coalition's Cancer Screening Certification, please be sure to complete the post-test to receive credit. All webinars and post-tests listed for each module must be completed to receive a certificate. So today's webinar is presented by Dr. Camille Faulkner of Faulkner Gynecologic Cancer Care and Heidi Parker of Immunize Nevada. Dr. Faulkner attended medical school at UC San Diego and completed a residency program in obstetrics and gynecology at William Boma Hospital. She returned to Southern California to practice general obstetrics and gynecology at Riverside County Regional Medical Center, while also working part-time in a virology lab at UC Irvine studying HPV. Dr. Faulkner then became an instructor in the Department of Obstetrics and Gynecology at the University of Oklahoma. There, she was certified in general obstetrics and gynecology with the American Board of Obstetrics and Gynecology and accepted to the University of Oklahoma's fellowship program in gynecologic oncology. In 2006, she completed this fellowship and moved to Las Vegas, where she began to practice gynecologic oncology. In 2008, Dr. Faulkner became certified in gynecologic oncology with the American Board of Obstetrics and Gynecology, and she opened Faulkner Gynecologic Cancer Care in Henderson in 2010. So, Dr. Faulkner, please take it away.
Okay, thank you. Thank you very much, Kristen. This is Camille Faulkner, and I just wanted to thank Kristen so much for inviting me to do this presentation. I am excited to share kind of all of this information. I have a lot of information to share with you, so I'm just going to get going. But I will take a look over and make sure, see if there are any questions being asked, so feel free to ask those. So today, as Kristen mentioned, we're going to be talking about cervical cancer screening. And basically, first, just he kind of gave you a very nice description of the things that my training. I said, wow, I guess all that is true. And I want to just say right now, I'm a gynecologic oncologist. And so I do have my practice in Henderson. And I enjoy taking care of a lot of the Women's Health Connection patients. And I know I'm looking kind of at the list of names who are here, and I know that that's what most of you do. They help these patients. And so I just wanted to let all of you know that this type of screening that we do is so important. And I hope by the end of the talk you'll really understand that what you're doing, it actually makes a huge difference. And a lot of times I think when you're in the medical profession, you wonder if what you're doing is actually helping people. But I think what we're doing for cervical cancer screening actually does, it literally does save women's lives. And so I'm so glad that we're able to offer this service to these women. And I wanted to just talk about what we're going to talk about today. We're going to talk about cervical cancer screening, the results of screening, and correct follow-up. We're also going to talk about the human papillomavirus, HPV, and its relationship to cervical cancer. And finally, we'll talk about cervical cancer prevention with HPV vaccination. And I'll just kind of give some background, and I know Heidi will be talking about the specifics with regards to Nevada. So if we get started, we can just say, first of all, what is cervical cancer? And we know that cervical cancer is a cancer that we don't hear a lot about. And actually, in the United States, they've nicknamed it the forgotten cancer. And the incidence in the U.S. is 13,240 women per year. And so over the course of a woman's lifetime, women in the U.S., there's a 0.6% chance. And about 4,170 women die per year. And so when you compare that to other cancers, women's cancers, it's actually pretty low. And that's why I think, unfortunately, it's kind of forgotten. So, like, for example, we usually hear a lot about breast cancer. You know, there's a lot of breast cancer awareness, breast cancer walks, and even, you know, you have a 1 in 8 chance or a 12.4% chance of getting breast cancer during your life. If you compare that to cervix, it's very different. Likewise, even the gynecologic cancer that has the highest incidence, which is uterine cancer, is only a 2.8% chance of getting this. But if we look throughout the world, it's actually very different. So throughout the world, cervical cancer is the most common cancer for women. And it does happen to women mainly in Africa, South America, and Central America. That's where most women develop cervical cancer in the world now. And the interesting, or I guess different and unfortunate thing about cervical cancer is that it tends to affect younger women. So the women that get diagnosed with cervical cancer are between the ages of 35 and 44, whereas most cancers certainly are elderly women. You know, most of my patients are actually between the age of 50 and 70 because that's when the other gynecologic cancers do happen. But even in the U.S., you know, this is a huge problem and was really one of the most common causes of death for women until we had, like, our great invention, okay, of the Pap Smear. So the Pap Smear is just, although no one likes to get a Pap Smear and it's, you know, uncomfortable for patients and all of that, it actually, it does save lives. And so that's going to be sort of the biggest screen that we talk about, but I will be talking about some other things as well. So before the United States had good access for Pap Smears, a lot of women died of cervical cancer here also. So the Pap Smear has really been the clue to bringing that incidence rate down. So if we talk about cervical cancer screening, so we're going to talk about the pelvic exam, we're going to talk about the Pap Smear, and I know a lot of places refer to this as the Pap test, but I actually still like the old term, which is the Pap Smear. We're going to talk about co-test or co-testing and exactly what that involves. I also wanted to mention a couple of other things, colposcopy, because typically depending on the Pap Smear results, patients have to have colposcopy, possible biopsy, and possible endocervical curettage, also known as ECC. Also, depending on the Pap Smear results, some patients actually need an endometrial biopsy for further evaluation. So I'll talk to you about that as well. And then finally, we'll go over the screening guidelines, which I think most people know, but we'll just chat a little bit about those. So if we talk first about what is a cancer screen, and I think that it's very important to know what a cancer screen is, because we know that a true cancer screen is supposed to detect cancer before symptoms appear. Okay, and there can be false positives and false negatives from screening. We do know that. And we know that cancer screens don't really give a diagnosis at that moment. They tell you there needs to be further evaluation. And so once again, the reason that the Pap Smear is just so great is because it's a true cancer screen. For most cancers, you don't detect them, until they're actually there. So there's all sorts of ways that we've attempted to find cancers. You know, we do blood tests for tumor markers. We check people's urine. We do imaging studies of all sorts, whether it's a chest X-ray or a CAT scan, ultrasound, PET scan, even mammograms. But when you think about these types of tests, typically you are picking up cancers after they are already there. And yes, we do consider that cancer screening, but a true cancer screen is when you detect cancer before the symptoms appear. And so if you talk about colonoscopy, yes, that actually is a cancer screen because the gastrointestinal doctor or colorectal doctor can find polyps, and these polyps are precancerous, and then those can be removed, and then that prevents the patient from getting colon cancer. But Pap Smear is really just a great screen, and so I want people to know that this is so important, and I try to emphasize this to all my patients that you shouldn't be afraid of Pap Smears. Pap Smears will tell us if there's something going on. An abnormal Pap Smear rarely indicates the presence of a cancer. It detects precancers, and that's what Pap Smears do. Precancers precancers are not dangerous. The reason why we're so excited about finding an abnormal Pap smear and following up with it is because we can prevent cancer. When you find a precancer, the precancers do not cause pain. They don't cause bleeding. You can't see them with the naked eye when you look at the cervix, and they're not dangerous. But we know that over time, and sometimes that time can be, 5 years is actually pretty quick. So we usually say 5 to 10 years. Some patients it's not for 15 or 20 years. These cancers can become, or these precancers can become cancers. And so that's really an important thing that I try to tell patients so that they don't get super nervous when they come see me for an abnormal Pap smear. So when we talk about the term pelvic exam, and that's a very vague term, and so it sort of changes. People will say, well, I had a Pap smear, I had a pelvic exam. People kind of use those terms interchangeably. But a true pelvic exam is just basically, just placement of the speculum, looking and, looking at the cervix, and then basically doing a Pap smear, or of course you can do other tests, cultures, vaginal swabs for vaginitis, those sorts of things. Bimanual exam is also typically part of a pelvic exam, where basically you're feeling the cervix, the uterus, and the ovaries with two hands, okay? And so that's why it's called bimanual. And, typically it's hard to feel a normal-sized uterus or ovaries unless the patient is really, really thin and really, really relaxed. But if there are some abnormalities or enlargements, you'll be able to feel them. And then most importantly, we have to look at the cervix, okay? And that's, easier said than done. Even now, I'm like, gosh, I've been doing this so long, and sometimes it's just hard to find women's cervixes because they can be different sizes, different locations. The patient can be really tense. The vaginal walls can be super relaxed. All this stuff can happen, but it is important to look at the cervix because that's how you can try to find out if everything's fine. Now, most of the things that you see on the cervix will actually be benign. So you can see Nabosian cysts, you can have polyps, there can be fibroids sometimes that you see on the cervix. There can be, women can have a very strangely shaped cervix, sometimes depending on the type of vaginal delivery that they had, or if they had, some procedure on their cervix. Women who are menopausal, if they have an atrophic cervix, a cervix or a vagina that doesn't get hormonal stimulation, you can have sort of a different look. Or you can have something called atropion, which basically is where the glandular cells that are typically in the center of the cervix actually come out a little bit on the face of the cervix. And typically this tissue looks kind of pink and sometimes can bleed a little bit when you touch it. And the other thing to understand is that a pelvic exam is so important because I sometimes will get referrals from other doctors, and basically they will, say, this patient, she's been having, this weird bleeding after intercourse, and, I did this ultrasound and the CAT scan, and they don't see anything, everything looks fine. But this is not, cervical cancer is not something that is usually diagnosed on an ultrasound or a CAT scan, unless the cancer gets huge. So you really have to have a doctor look at the cervix, or someone look at the cervix to make sure that it looks fine. So now we're going to talk about the Pap smear. So this is, of course, the Pap smear is great. It's awesome. You need to let the patients know this. And this was discovered in 1927 by the Greek doctor, Dr. Georgios Papanikolaou. And actually at the same time, there was another doctor in Romania who made a very similar discovery the same year, and his name was Dr. Babis, and I'm not sure how to pronounce that. And actually, so in Romania, they don't refer to this as the Pap test or the Pap smear. They actually call it the Babis Papanikolaou. They actually include both of the names in the name of that test. So this was discovered, and then regular screening was started in 1941 in the United States. And so it was after that time that the rates of cervical cancer began to drop in the United States. And so a Pap smear basically involves collecting cells off of the cervix, and then those cells are sent away to a pathologist. And so this is referred to as cytology. Anytime the pathologist looks at cells under the microscope, not like tissue, that's a biopsy. We'll talk about that. But looking at cells is called cytology. And there's two types of cells that the pathologist likes to look at for a Pap smear. The squamous cells, which are the cells that are on the outside of the cervix, and the glandular cells, also called adeno or endocervical cells, which are on the inside of the cervix. And so basically, this is what the pathologist is trying to do. So when we do a Pap smear, it's this goal of placing the speculum. The speculum goes in, and basically we see this pink donut. And, traditionally we use a small brush and a spatula, okay, to take cells. The brush took cells off the center of the cervix. The spatula took cells off of the surface of the cervix, the external area. And now some doctors, I like to use the broom, which is basically what is typically given, I think, with the thin prep, is that you have, it's got a purple sort of stem on it, and then you can use it with, you can get samples of the internal cells, which are the endocervical cells, and the outside cells. And so the types of Pap smear, there's liquid-based Pap smears, which is what most of us are familiar with now. And those are typically thin preps, but there are other people that make them. And then there's traditional Pap smears. So the old style Pap smear is when you basically got cells, you rubbed them on a slide, and then you had to, use the fixative stuff to spray on it, okay? And then they sent those away. But now basically, you have to do the correct number of turns on your little Pap smear so that you're getting enough cells, and then you shake it in the liquid, okay? And then the liquid sits there. That goes to the lab. The pathologist then squeezes out some of that liquid onto a slide, and once again looks at it under the microscope. So this is really, this liquid base is sort of what's always used. And we used to think that the liquid base, you could get better results and that sort of thing, but now they really feel that probably the results that you get are about the same between liquid-based and traditional, but the biggest difference is you have fewer unsatisfactory Pap smears with liquid-based, and also you're able to use the solution to do your HPV testing, which is really what we end up needing for our evaluation now. So the goal, remember, is to detect precancer, okay? Another word for precancer is dysplasia, and that's what a Pap smear is for, okay? It really doesn't, sometimes you'll pick up cancers, but that's not what it's for. And it's also not for the vagina. The Pap smear really hasn't been shown to work very well for the vagina. Vaginal cancers are very unusual, very rare. So at times, it can detect not only cancer of the cervix, it's very unusual, but also cancer of the uterus, because the cells inside the uterus, that's in the endometrium, which is the inner lining, can down onto the Pap smear. So typically that's not why we do Pap smears. I've had patients with ovarian cancer that will say, Dr. Faulkner, I had a normal Pap smear last year, and now I have ovarian cancer. Well, that's because this Pap smear doesn't find any of that. It's specifically for the cervix. So when we talk about co-test, okay, I'm going to move on to co-testing. Co-testing is really, it's basically where you're doing your cytology with your Pap smear, but you're also checking for HPV. So before we talk more about the co-test, I want to just talk about HPV, or human papillomavirus. So this is a virus that likes certain types of cells in our body, okay? It likes the cervix, it likes the vagina, it likes the vulva, the anus, the penis, the nose, the mouth, the throat, the trachea, and even the inner eyelids. I didn't realize there was squamous cells there. So we know that there's two sort of basic groups of HPV. There's the cutaneous ones, okay, like people get warts on their hands and feet, and we're not talking about those, okay? We're talking about the mucosal ones, and those include these two groups, high risk and low risk. So how do you get infected with HPV? Okay, so this is something that you get from skin-to-skin contact. Okay, it's not blood or body fluids like some of the other viruses or things that we can talk about. And so this typically happens when women and men have intercourse for the first time. Okay, so, but it can just be touching, okay, genital touching also, or any of those organs that we talked about which have squamous mucosa could have HPV, and if two of those things touch together, then you can actually have the HPV passing, okay? So, but, I kind of went through all the different things patients had asked me, like, can they get HPV from these things? So you can't get HPV from these things, not from a toilet seat, not from holding hands, not from hot tubs, swimming pools, dirty people, food, sharing dishes. I've had, patients ask me all this stuff, and that's not how you get HPV, okay? So in the prevention, basically, is, I guess, abstinence. If you don't have any sexual contact with people, you'll never get exposed to it, unless, I guess, I've had patients say, well, what if I'm with someone, I've never had any sexual interactions with someone, and then they haven't? Well, then I guess, yes, that no one would get HPV in that scenario, but that's such an unusual situation, I think, these days. But yes, that would be the case. So either, if people have fewer partners, then they're less likely to get the viruses because there are a number of them that you can get. Or if you have partners who have fewer partners, then you're going to be less likely to get it as well. But condoms don't really prevent HPV transmission because it's a skin-to-skin sort of thing, and so the condom doesn't really cover the whole, all of the skin area, and so you can still end up getting the virus. So just to know about HPV also, it was discovered in 1956, and in 1984, a Dr. Zerhausen, who was from Germany, he discovered that HPV causes cervical cancer, and he's still alive. He's like 82 years old now. And so there's this category of these two types of HPVs because, we need to know these because when we do the Pap smears and when we get these results, and we're like, wow, okay, what does all this mean? So that there are high-risk types and low-risk types. So high-risk type 16 is the cause of 50% of cervical cancers because we know that when HPV sits on these squamous mucosal cells that we talked about, it causes these precancerous changes. And this is all for the U.S. In the U.S., about HPV 18, about 10 to 15% of the cervical cancers are caused by those. And then you've got these other ones, 31, 33, 35, 39, 45, 51, 52, 56, 58, 59, and probably 68 are high-risk types. There are geographical differences, though, because I had a patient from Greece, and she was positive for HPV, and she was actually HPV 16 and 33 positive, and it turns out in Greece, for example, HPV 18 is very, very unusual. So it just depends on kind of where you live, but these are the numbers for the United States. Low-risk HPV is 6 and 11, and we know that 90% of genital warts are caused by low-risk HPV. So there's this discussion of once you get HPV, okay, we know it's very common to get it when you start having intercourse or sexual interactions, and then what happens? Where in most people, the virus ends up being sort of basically inactive or passive, and some people will call this being cleared. And I don't really like that term because it seems to imply that it'll be gone forever, and this virus is never gone forever, okay? So basically we can say that, the virus, when it's detectable, is active, and when it's undetectable, it's inactive or passive, okay? But we know that it can always become active in the future. So I'll have women that have been married for 20 years, and then all of a sudden they're HPV positive, and so they worry and say, well, was my husband with someone else, or what happened? And you can't really say that because this virus could have been in your body inactive for all this time, or perhaps the last time you had a Pap smear, it wasn't checked. That's another possibility. But we know that these viruses can become activated. So once they're in our body, they're there forever, and there's no cure to just get rid of HPV once you get it. So when we talk about co-test, okay, so what does that mean? Co-test means cytology, doing a Pap smear, and HPV performed at the same time. And this is actually preferred by almost all the organizations that come up with these different ways to, or the different frequency and the different ways of doing cervical cancer screening. Now, there's one organization which is called, it's the USPSTF, which is this United States Preventive, I'm forgetting, but task force are the last two letters. And so basically they don't think that it's any better than a regular Pap smear, but everyone else does. And so that's why most places do co-testing. But you don't have to do it, okay? It's the preferred method. You still just can do Pap smears, and that's fine too. And remember that co-testing is only for patients who are over 30, okay? And we'll talk about that with the screening because, these young patients, typically, if you test all of them, they're going to be HPV positive. So we don't do co-testing because finding out that all of these young women are HPV positive doesn't give us any more information. Before, there was what we called reflex testing, which really meant that, you would do a Pap smear, and then if the Pap smear was a certain result, then you would go ahead and do further evaluation with HPV. And that was the case, for example, with our active Pap smears. We're going to get into the different categories of Pap smears, but with active, if it was positive, you would do reflex testing. Now you don't do that so much, although you could do it with your young women. For example, if you had asthma and you wanted to figure out what to do with her, you still could do reflex testing. So the newest approach for screening. Why do we do co-testing? Why was this the recommendation? And the first reason is that, number one, you can detect some women who are missed by Pap smear alone. And usually that refers to these types of glandular abnormalities. We talk about the squamous cells on the outside of the cervix, the glandular cells on the inside of the cervix. Okay, these glandular cells are also called adeno cells, endocervical cells. And we know that you can have cervical cancers that are glandular, but they're less common. Maybe about 15% of cervical cancers are glandular. And you can have precancers that are glandular as well, but usually you don't. But the precancers that are glandular or the cancers that are glandular are more difficult to find because it's inside the cervix, and the Pap smear usually just doesn't get to it. And so we think that if you do HPV, you can probably catch some of these patients. Another reason that co-testing is used is for risk stratification. So what that means is that when you find someone that's got a normal Pap smear and HPV negative, you know that the chance of that patient getting, assuming that they've had no previous abnormal Pap smears or anything like that, you know that the chance of them getting a cervical precancer in the next few years is very low. And that's why they've been able to make that sort of recommendation for surveillance like 5 years. Like initially I was like, oh my gosh, 5 years without a Pap smear, but I guess the data sort of supports that, and so that's why they make that recommendation. So it sort of tells us that this group of women we don't really have to pay attention to, but women that are HPV positive, that HPV could sit there, and if it remains active, it can cause precancerous changes. So we pay attention more to those women. So we know that this co-testing is what's preferred. It's typically what's done at most of the doctors, with most of the doctors in the clinics that I work with. But there was some discussion in just doing a review last year where there were people that were questioning whether co-testing should still be recommended for cervical cancer screening. And so studies suggest that co-testing results in twice as many follow-up tests. So, excuse me, you know how you have to call patients, tell them, oh gosh, you've got an abnormal Pap or you have HPV positive, 16 or 18, you're going to have to come in for colposcopy. And so it results in like twice as many of these follow-up tests. And a lot of these studies suggest that you're not really picking up any more like CIN3, which is moderate, severe, or carcinoma in situ, or cervical cancer. So you're like, well, what's the point of doing this? So some of these studies suggested that really we should pick one. We should do Pap smear alone, or perhaps in the future we should do HPV alone. And that's just sort of getting more momentum where at some point we'll just test for HPV. If HPV is positive, then we would do a Pap smear, and then we would go from there. And so they also talk about this concept of home HPV test. So basically, people could be, at home, go to the pharmacy, buy a little home HPV test, go ahead, do a little swab in their vagina, and then decide if they needed to go to the doctor to get an actual sort of cytology Pap smear. And in countries where they don't have access to clinics or doctors or Pap smears, they actually they have tried to use sort of these home sort of HPV testing that would be helpful. So we'll see what happens in the future. Okay, so cervical cancer screening. I also wanted to talk about colposcopy. Okay, so colposcopy is basically depending on your Pap smear results, you get colposcopy, and then when I look at the colposcope, the patient comes in, basically you put in the speculum. The colposcope is like a big microscope. We look at the cervix. We know that we can't see precancerous cells with our naked eyes, but we do know that if we put vinegar or acetic acid on the cervix, we can see white changes if there's precancer that is present. So that's what we look for. And we also look for some vessel changes. One of them is called mosaic, which basically just looks like a cobblestone, these little kind of cobblestone outlined in red. Or you see punctation, which is just these dots. So these are things that you can see on the cervix when you put acetic acid. And if you see those things, then you can take a biopsy to try to prove that someone has a high-grade, severe, that would be moderate or severe precancer. The other thing I wanted to say is some of the Pap smears, the recommendation is actually to do endometrial sampling in addition to your colposcopy. And so that sampling can be in-office biopsy or, sorry, that got pushed up there. It should be dilation and curettage, another option for doing endometrial sampling. So now we're going to talk about screening guidelines, okay? And I think most of us sort of know this because we have to figure out, well, who needs screening and how often and how soon do they come back. So basically, when they decide cervical cancer screening, these different organizations come up with like all this information as to, and it's based on research, as to how often, how frequently patients should get Pap smears. And so the most recent recommendations came from 2012. And so you've got all these groups, like all these letters. So, you've got the American Cancer Society, you've got the American College of Obstetricians and Gynecologists, you've got, always forget ACP, I think it's the American College of Physicians, you have the American Society of Clinical Pathology, you have the American Society for Colposcopy and Cervical Pathology, that's the ASCCP. That's an important one. And actually, I was just looking at their website, and they basically said that they just want to be called ASCCP now. You don't have to, memorize what those stand for. And then finally, there's that U.S. Preventative Services. That's what that S was, Services Task Force. So all of these groups had recommendations, and they all ended up being about the same, and they all ended up coming out around 2012. So if we look at cervical cancer screening guidelines, we know that under 21, no screening is recommended. Okay, and this has been a change. 10 years ago or so, or I guess before 2012, it was always like, well, it depends on when the patient starts having intercourse. That's when it would start, et cetera. But now it's just less than 21, and that's because there are patients under the age of 21 who get diagnosed with cervical cancer, unfortunately, but the risk is so low. I think it's 0.1 of 1% of the cervical cancer diagnoses are in teenagers. So they figure, well, it's just not worth it to screen everybody for that small group of people. We also have ages 21 to 29. They need cytology every 3 years because they're not doing co-testing, okay, because we said it's too prevalent in that group, and finding HPV positivity just doesn't give you any more information. We have ages 30 to 65. They need cytology every 3 years, or, the preferred method, which is co-testing every 5 years. And then once they get to be 65, you can actually discontinue Pap smears if you have 3 normals or 3 normal cytology or 2 normal co-tests within 10 years. But certainly that is only for patients who really haven't had any abnormalities. Okay, so women who have been diagnosed with moderate or severe dysplasia, that's CIN2 or 3, or if they've had adenocarcinoma in situ, which is another precancer, or if they've had actual cervical cancer, then they must have had 20 years of normal Pap smears before you discontinue this. Okay, so please keep that in mind. These other patients, not all patients are going to fit into this category. If a patient has had a hysterectomy, okay, for benign indications, then certainly we don't do Pap smears. Okay, we used to do a lot of Pap smears on the vagina, and that's not necessary. So when we look at the screening results, okay, we're going to get into all of this stuff, what do we do with all of these different Pap smear results? Okay. So we know that they use something called the CHW terminology, okay, and typically we talk about these ASCCP guidelines and algorithms. So I'm certain everyone has kind of looked at these. They can be kind of confusing sometimes. I go and look at them and I'm like, wow, this is really confusing. Now you can sort of follow them, but I'm going to try to present it to you in a little bit sort of simpler fashion so that you can just sort of go away with some important things about all these Pap smears that are coming through. So really the most common abnormal Pap is ASCIS, okay? This is atypical squamous cells of undetermined significance. 10% of Pap smears are ASCIS. And then you've got L cell, which is low grade, okay? And a lot of these terms, the CHW terminology is interchanged with mild, moderate, severe, the CIN 1, 2, 3, and I'm going to show you sort of how all of those fall out. But it used to be very specific that Pap smears will only this terminology, and, the other sort of ways to describe things were other terminology, but now it's all interchanged. So biopsies, sometimes they'll say H-cell, Pap smears, sometimes they'll say mild, so you'll just see all of these terminologies, but I'll show you how they all kind of are similar. But for us, the biggest thing is to know L-cell, low-grade changes. Okay, a lot of patients have those too. H-cell, not as much. Okay, there just aren't as many of those. And the H-cell are patients that need to be paid attention to because ultimately they're going to need treatment. And then that's for high grade. And then the description of intraepithelial, that really refers to the fact that this is a precancer, okay? Intraepithelial means that it stays inside the cells. It doesn't travel. Precancers can't spread. I have patients say, oh my gosh, I have this cervical precancer, and what if it spreads to the rest of my body? Well, it doesn't. Cancers do that, but precancers do not. And then ASH is it uncommon Pap smear, a little newer type? We're not quite sure, how that's going to end up being, but it sort of is in the same category as HSIL, meaning that patients with ASH will need at least one of the options is for them to get treatment as well. So it's actually a very important group also that you need to kind of pay attention to. So if we look at the other types, we've got glandular results. Remember I talked to you about the squamous precancerous results, and then we've got these glandular results, okay? And this is AGC, okay, atypical glandular cells. So we've got AGC, NOS, which is not otherwise specified, okay? Before this terminology, at one point it was called AGC-US, that was undetermined significance. At one point it was AGUS, okay? But the problem with these terminologies is that they were confused with ASCUS. And ASCUS typically is not a very serious Pap smear, but AGUS, if they used to call AGUS, I still do that, but it's AGC-NOS, potentially can be very, very dangerous for these patients, okay? So these glandular abnormal Pap smears, they need to have very close follow-up because sometimes they indicate they're actually the problem. We've also got AGC, favored endometrial cells. We talked about the fact that you can have cells that sort of float down from the inside of the uterus and land on your Pap smear, okay? If you have favored endometrial cells, that means the pathologist suspects that this may have been the case. Once again, this isn't a diagnosis. We don't know it for sure, but it means you need to think about that, and typically these patients need an endometrial biopsy, like we talked about. And then there's the AGC-favored neoplasia, which typically, certainly can mean an adeno type of problem, or sometimes it actually just means your regular squamous problem. And then you've got adenocarcinoma in situ, okay? So this term carcinoma, okay, even though it's cancer, this is not invasive cancer. This is still precancer, just like we have carcinoma in situ, which is basically the squamous version of this. So adenocarcinoma in situ is a precancer that you can see, and sometimes you'll get a Pap smear with AIS. I know certainly we had a patient with AIS on her Pap smear. But in situ is very important. It means precancer. Okay, now it may be different in other parts of the body. So for the cervix, even though it says adenocarcinoma, if it says in situ, it's still precancer, and so it's not treated as a regular cancer. And then sometimes on Pap smears, you actually will get invasive cancer, squamous cell carcinoma, we said the most common type, or you can get adenocarcinomas, the ones that develop from the glandular cells that are inside the cervix. So these are sort of all the different terminologies, and I'm sorry, they got kind of mixed up here. So if the mild and CIN1, you can kind of look at that, and basically these all mean the same thing, okay, mild CIN1, and that stands for cervical and epithelial neoplasia, and L-cell. Then you've got moderate CIN2, H-cell. Okay, so H-cell includes all these things. H-cell includes moderate dysplasia, severe dysplasia, okay, and also carcinoma in situ. It's all H-cell. If you have CIN2, moderate, CIN3 includes severe and carcinoma in situ. Okay, see, all these terms, they sort of intermix them now. So there used to be a certain term for biopsy, a certain term for Pap smear, and now they're just everywhere. And then we have adenocarcinoma in situ again, we talked about this. These are precancers. Even though the word carcinoma or adenocarcinoma is there, they're still precancers. So now if we look at HPV testing, okay, so you get these Pap smear results. You've got these HPV tests, okay? You're like, gosh, what do I do with this? So basically we know that it depends, okay? There are some labs that specifically are testing for high-risk HPV. So the results that you get will say, oh, I've got HPV 16, or I've got HPV 18, or sometimes you can have both, or you can have HPV other. Okay, so there's usually those three categories, and you can be positive in each one of those categories. And then some labs, basically, they even check for the lowest HPV. Like sometimes I'll have some doctors that are referring patients to me, and their HPV tests basically say 16, 18, 6, and 11. Okay, I've also had doctors send me patients because they say, oh, this patient needs evaluation, needs colposcopy, and basically all they have positive HPV 6 and 11. Okay, those patients don't need follow-up because when we talk about positive HPV, we're only talking about the high-risk type. And then there are some labs that just test for high-risk HPV, and that high risk is either just a positive or a negative result. Okay, they don't break it down. So that's just something to notice when you're sort of looking at that. Also, just remember, so when we think about what do we do with these patients, how do we sort of put them into different categories? The general rule is that, first of all, if you have an abnormal Pap smear, the patient is going to need to have colposcopy. Okay, that's just sort of the bottom rule. Now, there are some exceptions. There are some differences for young women. And this is sort of something new that they developed in 2012, that young women ages 21 to 24, there are some other options for management, okay? And some results may have the option of colposcopy versus something else. But basically, if you just remember that any abnormal Pap smear now needs a colposcopy, you're going to be in good shape. Now, there are exceptions, okay? There's one exception for that. That's for ASTIS, okay? So for ASTIS, if you have an HPV negative Pap smear that is ASTIS positive, or ASTIS is the result, then these patients do not have to come for colposcopy, okay? These patients, and we used to say it was a normal Pap smear, but we can't really say that now because they can't come back in 5 years like the normal Pap smears, but they can come back for co-testing in 3 years, okay? Now, if you have a patient who gets ASTIS and doesn't have an HPV, okay, because that's sometimes, for example, if they're less than age 30, I mean, they didn't have HPV, or, not all doctors have to do HPV. Maybe they just had an ASTIS Pap, and you don't know what their HPV is. Then they need to follow up in 1 year, okay? But that's really the only exception to this rule, that if the Pap is abnormal, they need to have colposcopy. Also remember, you've got your glandular results, right? These AGCs, we talked about the 3 different groups. You've got your AGC hyphen NOS, you've got your AGC hyphen favor endometrial cells, and you have your AGC favor neoplasia. Remember, those groups typically need endometrial biopsy also. So that's just something to remember for these patients. So pay close attention to the glandular Pap smear results, okay? The AGC and the AIS, because sometimes those used to be kind of thrown in with the ASTIS, and they're very different type of Pap smears, because some of those patients end up actually having cancer. So it shouldn't be confused. And also, your HSIL and your AST-H, that typically those patients are going to require treatment because they have high-grade lesions. Okay, so the other Pap smears, other situations that some patients or some people will want to know about is if you have a cytology normal Pap smear, but then it's HPV positive. Okay, what do you do with these people? So if it's HPV 16 or 18, then they need to come for colposcopy, okay? But like I said, not everyone gets that specific typing when they're HPV positive. Some of the HPV testing just tells you if it's high-risk positive or not. So if you've got just an HPV, just a general positive result, or if you have an HPV other, that's sort of typically the option if you've got the 16 and 18, and they need to come back for another Pap smear in a year. And then if it's abnormal again, then they're going to have to go to colposcopy. If you have unsatisfactory Pap smears for patients, then you need to repeat it in 2 to 4 months, okay? And if it's HPV positive, you can go to colposcopy. So, okay, who needs treatment? So typically, we sort of talked about this before, and the treatment that I typically do is a LEAP procedure. This is a loop electrosurgical excision procedure. So we know that the HSIL patients need treatment. We need those that the AST-H patients need treatment. Now, there is other options for management of AST-H, but I typically do think that these patients need treatment as well. And then if you do have, other Pap smear results that on biopsy you end up getting CIN2 or 3, okay, so that involves moderate, severe, or carcinoma in situ, then those people need treatment. And then ultimately they need follow-up Pap smears. A special note about this adenocarcinoma in situ, I talked about it is a precancer, but let's say they have a LEAP and you find that on their LEAP, and ultimately those patients do need hysterectomy. That's the standard of care. Although they can be managed conservatively, but the standard of care is for them to have a hysterectomy. Okay, so I'm briefly going to just talk about HPV vaccines because I know we need to get into that with Heidi. So let me just briefly just go over just a few more slides about HPV vaccines, and then we will be winding down. The HPV vaccines, it was first released in 2006, and there's different types of vaccines that have been available. There's a bivalent HPV vaccine, which is just 16 and 18, and is Cervical. but it was not FDA approved for boys to receive. There's the quadrivalent vaccine, which is the Gardasil, and that's the one that most people knew about, and that was HPV 16 and 18, so you get those two high-risk viruses that were basically, at least the most prevalent, the most common in the United States, and then you had the low risk, the 6 and 11, and now there's the 9-valent HPV vaccine, which basically you get 9 different HPV viruses, 16, 18, 31, 33, 45, 52, 58, 6, and 11, and this was approved in 2014. So when we talk about HPV vaccine, we know that the recommendations are for ages 11 and 12. Actually, I'm sorry, this should say ages 10 and 9 are okay also. Sorry about that. And then ages 13 to 26 is okay still for girls to receive it, or I should say young women. And then ages 13 to 21 for boys. And then they had like ages 22 to 26 for some young men if they're in different categories, if they're having sex with other men, that sort of thing. But ideally, you need to have this before patients start their sexual activity. Sometimes you can still get it, and the vaccine companies will say, yeah, you can still get them because there's a lot of different viruses, and perhaps you have one virus, but you will get protection from another virus. So it is true, but I think the recommendation is that children need to receive this before sexual activity. And so under the age of 15, there's 2 doses that are now recommended, and those doses need to be 6 to 12 months apart. They came up with that new recommendation in 2016. Otherwise, you have to get the 3 doses if you are older than that. And the biggest side effect is pain at the injection site, 70%, and then other side effects that people talk about, the fever, headache, fatigue, it's rare, about 2%. So when we talk about the HPV vaccine, does it work? In the U.S., it initially predicted that if an adequate number of girls were vaccinated and women had Pap smears, it was thought that we could actually eliminate cervical cancer by the year 2050. I mean, that would be amazing if that were the case. And then we could even start doing Pap smears at a later age, like age 25. So it was never that this HPV vaccine would say we never have to have Pap smears again. That really wasn't what the purpose of it. But it was made to work in conjunction with getting the Pap smear. But in the United States, there have been low levels of vaccination. And I think actually, though, Nevada's doing okay. So maybe Heidi will talk about that. But physically it's lower. Now, other countries, they mandate the vaccination, okay? They say that you have to get it in order to go to school. And so in Australia, like, for example, there's an 80% vaccination rate, and they've seen a huge decrease in these things, 90% decrease in warts, 45% decrease in L-still Pap smears, or those mild changes, and then 85% decrease in H-still, which are kind of these high-grade changes. So ultimately, it's going to take us a little while to see what the results are for these increased vaccination rates, because we know that the process of precancers becoming cancers is it's not fast. It takes place over years. But ultimately, it seems like, they're going to have a much decreased rate of cervical cancer in that country. So in conclusion, I would just like to say that the Pap smear is a unique and effective screen for cervical cancer. And remember, it's a true screen. I mean, these women, when we do root procedures on these ladies, that have this severe dysplasia, moderate severe dysplasia, we really are literally kind of saving these ladies' lives, if they had not come in and gotten a Pap smear. So just remember that when you're taking care of these patients. And we know that, as you get more data, because they're always doing studies about what's the best way to do Pap smears, what's the best way, because we know that if you spread out, every 5 years, that's a long time. We know that we are going to be missing a few more patients than we would, for example, if we did every 3 years with co-testing. But these recommendations will change, okay? And the goal for these committees is that they look at the studies, they look at the data, and they come up with further recommendations. So, of course, we will see some changes regarding cytology and HPV testing, and it'll be kind of interesting to see how we can optimize this even further. And then finally, the impact of HPV vaccine on Pap smear screening is really yet to be seen in the U.S. because we just don't have a lot of children getting the vaccinations. But data does suggest that cervical cancers will become much rarer if more children receive their vaccinations. So I wanted to thank everyone so much for your attention, and certainly I am open to any questions if you have them. Thank you.
Thank you so much, Dr. Faulkner. That was fantastic. We're going to jump right into our next presenter. If you do have questions for Dr. Faulkner, go ahead and enter them down into the chat box, and we will get to those. Our next presenter is Heidi Parker. As Immunize Nevada's Executive Director, Heidi leads and engages a diverse and passionate coalition of staff, volunteers, partners, and funders across Nevada's rural, urban, and frontier communities. Under her leadership, Immunize Nevada is deeply involved in community outreach, collaborative projects, and fundraising efforts aimed at helping close the vaccination gap Nevada faces. Heidi, I'm going to go ahead and turn it over to you.
Great. Thank you so much, Kristen. I am going to talk a little bit today about myths and facts that we typically hear about HPV vaccine. And again, any questions or comments, go ahead and type them in and we'll answer them as well. So I want to thank Dr. Faulkner for that great overview. And I think one part is that education is really key to preventing HPV, and we have the tools to help you do that. But unfortunately, the myths and rumors that are out there really scare people away from this life-saving vaccine. And so hopefully today some of the information I present will help you. So right now, we are at about 60% of Nevada teens are not fully up to date with their HPV vaccine, which means they're not fully protected. With that first dose of vaccine, we're doing much better. So we're actually 15th in the U.S. right now, but we have to get these kids back in for that up-to-date finishing of the series, whether it's an additional 1 or 2 doses. And I think it's really important to think about this in the context of parenting. You know, we don't put helmets on our kids after they have a bike crash, so we really should not be waiting to vaccinate our teens. I'm going to skip over these next couple of slides because Dr. Faulkner did a great job talking about the vaccine and the recommendations. With studies so far, we do know that we've seen a 71% drop in infections with the HPV types that she was talking about. So we're on our way to hopefully seeing that cervical cancer and other cancer reduction in the near future. And again, because of just science and the research that we continue to do on vaccines, we are now able to only have 2 doses if our boys and girls get them before their 15th birthday. So some of the myths that we continue to hear, I'm going to go over quickly, and hopefully these are ones that you've heard, and maybe these facts will help you address them. So the first myth is that the HPV vaccine has dangerous side effects. So it is safe, FDA approved. Like anything, you know, there may have mild reactions. Most commonly reported are pain or redness in that arm. My son got his 3 shots, and he did have a pretty sore arm afterwards, but that was it. And so that's what we know is most reported. Again, on social media, online, there tends to be stories that circulate. A lot of those are definitely not contributed from the HPV vaccine. They come from other sources, but sometimes it's just a timing factor, and that's when those stories start circulating. Another myth, the HPV vaccine causes fertility problems. Again, we actually know that the vaccine can help protect women from future fertility problems when they, especially looking at some of the after effects of the cervical cancer treatments and what Dr. Faulkner was talking about can complicate labor, and we've heard that from some physicians and doulas that have worked with moms. And so we know that the HPV vaccine is actually a safe way to help protect women's health and their ability to have healthy babies. Another myth we still hear, unfortunately, just from the onset of when the vaccine was first released, is that the HPV vaccine is only for girls. In fact, it is recommended for boys, and it can prevent future infections that lead to cancers of penis, anus, oral cancer, and we're seeing actually a very high rate of those cancers in men, and you might be hearing those stories in the news. Some celebrities have come forth with oral cancer stories, and it is definitely rising. So, and definitely important to make sure our boys are vaccinated. Another myth that Dr. Faulkner talked about: you must have sexual intercourse to get HPV. That skin-to-skin contact is how it's spread. So we know that people who haven't had intercourse have become infected. And again, that condom use can help, but doesn't completely protect against the virus. There are treatments for HPV. That's another myth. So there's not treatments for the actual virus, but again, there's the HPV vaccine helps prevent that initial infection, and then there's treatment for genital warts and etc. The HPV vaccine increases sexual activity. So this is one myth that we do hear often from parents. They're really concerned that if they vaccinate their preteens, that it's going to increase their activity or cause them to become promiscuous. There's no research linking this. They have actually done studies, and those who have gotten vaccinated did not start having sex earlier, or they did not have more partners after they become sexually active. I think this is really key to keep in mind. Conversations, like I know when my son got vaccinated, we talked about the cancer piece of it. We talked about the things that he'd learned in his SHARE program, and that some of those viruses that they discussed are what can potentially cause cancer. And he understood that, and we didn't have to have a long conversation, and it just was part of his 7th grade bundle, which also is Tdap and meningococcal. So it can be a very simple conversation. Another myth: if I stay with one partner, I won't get HPV. Being in that monogamous relationship isn't a guarantee. Again, as Dr. Faulkner talked about, you can have HPV and have had it from a long time ago partner. If that person has been with somebody else who had HPV, they can still give it to you. So even if you are going into a relationship not having had that contact, you can still potentially get HPV. So we want people to make sure that if you've had one partner or 100, you still have that chance to get HPV. My partner tested negative for STIs, so they don't have HPV. We hear this often too. Unfortunately, that routine testing for STIs does not always include HPV, again, even in women, unless that abnormal result occurs as discussed. And right now there is not a test that's used for men, so it's even more important, again, that we're vaccinating our boys. So Immunize Nevada has a comprehensive website where we have a whole entire section devoted to HPV information. So immunizevada.org/HPV-free-NV has lots of resources available on it for answering FAQs. We update it regularly. There's also a resource on there for talking to parents about the HPV vaccine. And that resource is great because it's conversation, like kind of clips that you can use. So if a parent's concerned about like why their child might need HPV vaccine at such a young age, or why is this vaccine, like, is it recommended or required? Are they really at risk? So it goes over a lot of the standard questions that parents might have outside of myths that they might be hearing online. And so we really recommend using that that sheet with the talking points that are on it, because it helps drive a conversation that you may not have all the resources to use. And the CDC also has a couple other pieces of information and resources. They have short videos and other ways to have those conversations to help you when you are talking with parents or patients. We also have Healthy Young NV, which is a youth and young adult driven website. So it's focused on vaccines, but additionally it has information about drug and alcohol use, suicide prevention, healthy relationships, and that's a partner-driven website with our coalition partners. And there's resources on there as well for youth and young adults to empower themselves in their healthcare decisions. And there's some videos and great things to help with HPV on that site as well. And then you can also follow us on social media. We do post regularly about cancer prevention, HPV, survivor stories, and any current news or updates. We do share on Facebook, Twitter, and Instagram, and so we're always available to answer questions through those platforms or respond to comments as well. So those are my myths and facts for you today, and I think we're available to open it up for questions.
Thank you so much, Heidi. That was really great. I think a lot of people don't really think about some of those myths, so thank you for clearing those up. We haven't received any questions yet in the chat box, but if you have any questions, feel free to type them in. We'll just give everybody a minute if you have anything to type. And just as a reminder, the Women's Health Connection, which you are all familiar with, I hope, does have all of the Pap testing and diagnostics covered for participants in the program, as well as treatment in Medicaid for women that qualify. So awesome public health opportunity for women to get screened and treated for cervical cancer.
Kristen, I'll make a quick comment about vaccine availability for over the age of 18. So the state of Nevada has a program called 317 vaccine, and that provides low or no cost vaccine to uninsured adults or adults who have some type of coverage that doesn't include vaccines. And HPV vaccine is available in that program, and all of the health districts and the community health nurses do participate in that program, and so HPV vaccine should be available through that. And then as well as for under 18, it is available through the Vaccines for Children program.
Fantastic. Well, it doesn't look like we have any questions so far, so we will go ahead and wrap this up. If you think of questions regarding Women's Health Connection, cervical cancer screening, or HPV, feel free to send them over to me at kristen@nevadacancercoalition.org, and I will get answers for you from our presenters or from the Women's Health Connection program. Our next webinar is scheduled for June 25th at 2 p.m. regarding cancer screening barriers. So feel free to, that's going to be a roundtable discussion, and we will be talking about barriers and looking for solutions. So if you have barriers, please feel free to send them over to us, and we will include those in that discussion. Thank you everyone for joining us today. As I mentioned, the recording for this webinar as well as the link to the post-test will be posted by tomorrow morning. So go ahead to our website and check that out if you are planning to take the post-test. Thank you again, Dr. Faulkner. Thank you again, Heidi. And we hope everyone has a great day.
Thank you, Kristen.
Thank you.
Thank you.
Bye-bye.